Hello, ladies and gentlemen. Today, our main topic is feeding, eating, and swallowing. There are a lot of reasons your kid might have problem with eating, and one may be because of sensory processing disorder. So I'm here to share occupational therapy intervention that can help the kids that have sensory processing disorder that giving them a hard time during eating. Before we go deep into that, I'm going to talk a little bit more about sensory processing problem that may happen to your kid, such as oral hypersensitivity, which is hypersensitivity to food taste, textures, or smells, which can create such significant problem in oral feeding. This kind of kid may turn away from feeding or brushing activities, also restrict food variety, gag frequently, or difficulty suggesting to age-appropriate food texture. But hey, oral hypersensitivity is also commonly happen to children who have received extensive medical procedures like this that may have caused ongoing distress, gagging, or pain. This is going to affect the development of their sensory system. Besides children that undergo medical thingy, infants also have this thing we call early feeding problems such as gastroesophageal reflux or swallowing difficulties, which can create negative involvement between food consumption and sensory discomfort. So that's two. And now other than that, one that commonly exhibits oral hypersensitivity is children with development and neurological condition, example like these kids. Oh, that is a long intro. Okay, now we move forward to the intervention. There are two approaches. One is a behavioral approach, desensitization, and other is using sensory integrative FOR, which is application of deep pressure and proprioceptive experience. We can mix these two approaches for gradual oral sensory exploration around play and positive experience to reduce oral hypersensitivity. One thing you need to know, children may tolerate more sensory input if the activity is under their control, in context of motivation and developmentally appropriate play activity. Therapists may also engage the child in songs and games to encourage self-directed touch, like playing dress-up with hats, scarves, or sunglasses, tachi-tachi thingy. Why, you may ask? This activity is to create balance of stimulating and calming sensory input to produce adaptive, more normalized response from child. So now, children will gradually improve acceptance of occupational therapy's directed touch. How? It is with firm pressure that is applied distantly on the body, such as arms and shoulders, before moving to touch near the face. Moving forward, now we can start stimulating within the mouth area. We can use tools like glove finger, vibrating toys, warm cloth, nude brush, infant or children toothbrush, or teething rings, so they can explore them with their hands, face, and mouth. Firm pressure to child's gum or palates is really helpful in reducing oral hypersensitivity. For older children, they can play with whistles, oral sound-making games, bubbles, and blow toys since their gums are more mature. Remember when I said they may be hypersensitive to food taste and textures? Therapists can try to introduce new flavor and texture gradually. Again, how? With spoons, chewy tube, or teething rings, dip it into new flavor of food. We can also gradually thicken the food. Combine strained baby food with pureed table food for strong flavors and change the food temperature to grow the child's sensory experience. Don't forget to encourage them, okay? They did the exploration and feeding attempts. Surely they do deserve a little bit of a compliment. Hey yo, let's not forget the kids with oral hypersensitivity. The kids that have low sensory registration, which may demonstrate poor oral awareness. We can see the sign when the children frequently seek oral sensory stimulation by mouthing their hands, toys, or clothing for longer than expected, decrease awareness of drooling, try to overstuff their mouth when eating, or demonstrate preference for specific eliciting food textures or flavor. So, how do we fix this? OT can set up a treatment program which can provide enhanced oral sensory input intermittently throughout the day. Like during oral activities, we give a little bit of twist by using cold washcloth, vibrating toothbrush, or oral motor toy. During meal times, food with strong flavors and served cold may give additional sensory cues. For child that overstuff their mouth while eating, try to give a close supervision for their safety. Thank you. Hello guys! Behavioral intervention for feeding. OT can create new positive interaction and child associations around feeding activities and mealtimes. It's obviously frustrating when kids refuse to eat. Therapists and caregivers need to relax, confident, and caring demeanor when implementing behavioral intervention. Giving them turn and choices will let them feel the sense of control. At the same moment, their willingness to participate will increase. For example, caregiver may offer choice of 2 different foods or what cup they prefer. Behavior management intervention include the use of positive reinforcement toward decent behavior and ignoring or redirecting the unpleasant or undesired behavior. Positive reinforcement and regular exposure to non-preferred food can significantly improve the oral consumption and self-feeding skills. Therapists need to decide the praise and reinforcement that's suitable for each individual child. Here are some examples of positive reinforcement: social attention, verbal praise, music, favorite toys, stickers, access to small prize box, video games, or television. However, using food as enforcer is a no-go. Why? Because it may create more poor interest in less preferred food. Their interest in undesired food will only be depending on food rewarded, which is not effective to develop good eating habit. And if the child is not motivated to earn the prize, the intervention is hardly successful. Also, try to hold the toy or activity that is used as a reward outside of feeding activities. If the child has free access to the enforcement, the child will not feel motivated to earn it during mealtime. You wouldn't like something that you can have easily as a reward, right? So here's the thing, instead of giving them a big job to be done, therapists will try to break the activity down into small achievable steps and provide clear expectation. Consistent success is a must before increase the expectation on the next step. When behavioral strategies are implemented in gradual progression of new skills, positive reinforcement, and clear expectation, the child can learn to trust the therapist or caregiver, which lead to decrease of negative behavior quickly, in frequency, and intensity. Other intervention is therapists can suggest use of visual schedule or timer set in advance to help the child clearly understand when the activity is finished, rather than having a parent end the meals when the child's behavior has escalated. This clear end to the activity may also help the child transition from a difficult or new task back to the usual routine of feeding or post-mealtime activity. Hello guys! Intervention for food refusal and selectivity. I'm going to share 4 interventions in this video. Okay, number 1, environmental adaptation. Provide structured meal plan and consistent feeding times. This plan may include providing reinforcement, for example, access to preferred toy if the child is consistently testing new foods. Initially, presenting very small bite of the new food and requiring the child sit at the table for established amount of time before being allowed to leave. Child need to eat at a consistent location and consistent length of meal time. Reduce grazing or excessive liquid consumptions outside of meal. By doing so, it will promote hunger cues, limit access to less nutritious food, and create structure within the meal to establish positive eating pattern. The occupational therapist can make suggestions to modify the environment, such as dimming the light or playing soft music, which can help reduce the child's general arousal levels and facilitate his or her ability to tolerate the sensory stressor presented by food. Alright, next, introduce new food. Introduce new smell and taste carefully and gradually by allowing child who have tactile, gustatory, or olfactory hypersensitivity to explore food at their comfort level. Introduce new food that child prefers before introducing completely novel food. Non-preferred food can also be paired with preferred food at mealtime. Present food in different forms. Food can be prepared or offered in different ways, and a child may dislike a food offered in one manner but like it if offered in another way. For example, carrot can be offered cooked with a meal or raw as a snack, either cut into sticks or grated. Occupational therapists can help family members to continue offering small amounts of new food across multiple meal sessions to allow child in sufficient time to adapt a new taste or texture. Take your time. It can be between 15 to 20 exposures or offerings before a child is willingly to put new food in their mouth. Try not to rush the process. Keep offering the food and don't give up before you have offered the food at least 20 times. Moving forward, number 3, sensory integration intervention. Occupational therapy provides activities that incorporate deep touch pressure and proprioception. The therapy room in the clinic where the treatment took place are equipped with therapeutic equipment such as swings, therapeutic balls, trampolines, and variety of materials that provide tactile input. Oral sensorimotor activities designed to promote more typical sensory response and improve occupational performance during feeding. Oral sensorimotor activities included games with blowing toys, vibrating oral toys, and different texture chewing toys. Linear vestibular, proprioceptive, and deep touch input were provided in order to optimize level of alertness and promote a more proactive attitude toward the acceptance of new foods and textures in preparation for therapeutic meals at the end of occupational therapy session. Last but not least, number 4, alternative nutrition nutritional intervention. This intervention providing high dose of vitamin supplements and/or dietary restriction for child with ASD. Occupational therapists must consider the impact for the intervention for child with severe food selectivity and food refusal behavior. Consultation with registered dietitian or physician is necessary to address intake and growth as well as monitor for negative side effects from high dose of supplement. And those are 4 interventions for food refusal and selectivity. Thank you.